Good evening, doctors. This is BJ Lunston and Mike Braun and Jason Budrow with Avalon BioMed. We're pleased to have you join us tonight here with Dr. Antonio Berto. We're pleased to have Dr. Antonio Berto speak here on past, present, and future of endodontics, where science meets shaping. We've been able to know Dr. Berto here for the last 15 years and gotten to know him personally and clinically. And he has a dynamic story connecting with you and your peers, not only nationally, but internationally. Dr. Antonio Berto is in private practice in Dallas, Texas. He earned his undergraduate degree or his postgrad or his dental degree from University of Madrid in 2005, and then also his postgraduate degree from Baylor in 2009. He practices at North Texas Endodontic Associates with Dr. Witherspoon, Regan, and Tam, and we're pleased to have him speak here this evening. A little bit of the housekeeping items here to think about here tonight to earn your certificates of CE credits. To get the credits, you have to participate for the full duration of the webinar, and you will receive a post webinar survey after the lecture is completed the following day. In order to get the credits, you will complete the survey and obtain the credits thereafter. Also, on the lower hand of the webinar room, you have a chat platform. Please ask questions there, and Dr. Berto will answer those at the end of his presentation. So without further ado, Dr. Antonio Berto, thank you for your time this evening.
Today we're here to talk about the past, the present, and the future of Endo, and introducing you to a new concept called nanotechnology. I'm going to try to make this lecture as philosophical as possible. This is basically showing you what I do on my everyday clinical practice, and we'll try to make it as little commercial as we can. So before we start, I need to thank this group of individuals for making this possible. I've been around the endo world almost for 20 years. And I can tell you that, in my opinion, right now, Avalon BioMed is the top company in endodontics in the United States. And that's all thanks to these guys. Top company because they've been on the forefront of innovation, technology, and education. This is a company led by endodontists for endodontists. And whenever we ask for something, they deliver. And today's presentation is part of it. So again, thank you, all six of you, and everybody that is behind the scene as well. So with that, let's get into it. I hope everybody had a great end of the year and beginning of 26. This is the way my year finished in 2025. I was privileged enough to be invited to lecture at the Endo APEC 2025 with this group of incredible clinicians, some of the most respected doctors and endodontists around the world. But mainly, my biggest privilege was sharing my days with my friend, my mentor, and my brother, Dr. Mo Fayyad. It was a phenomenal trip, phenomenal meeting. And after that, we came back home to Dallas, work a little bit, and this year, the way the holidays kind of came, it was really nice to take some days off with the family. And we went to Guatemala to visit my wife's family. This year, I had one of my best buddies from dental school, Rafael Corda, coming with his family. So we got to travel a little bit. And we went to visit within Guatemala, these Mayan ruins in Tikal. So for anybody normal, you'll just come here and look at these wonders of nature and take pictures and wonder how those were done. I'm sure I'm not the only one in the audience that you look at that and you cannot think other than Endo. When I was looking at those pyramids, I'm thinking on a file passing the foramen and the apex locator reading red, or I'm thinking on Cliff Rattle talking about the triad of success, or as a matter of fact, as thinking on a pro taper. But when I was looking at the Jaguar pyramid, there was one thing that came to my mind. I was already thinking on how to put this lecture together, and it brought me back to the beginning of my private practice. That was back in 2009. And as you know, when the referrals have a relationship with another endodontist, it's very difficult to break that relationship. So back then, I was thinking on how to be able to show my work through some of these people that were not giving me an opportunity. And that's when I created this Facebook page. That was way before any of these endo influencers or anything like that. And interestingly enough, I got an audience much differently than what I was expecting. A lot of people from all over the world, and within 3-4 days, had a bunch of likes. But unfortunately, it got old pretty quickly. Why is that? Because I will always get the same type of questions whenever I will post a case. The questions were, what type of file, how did you upgrade, and what type of sealer? As if those three were the only things that you need to do to get to excellence in endodontics. And that's where the Jaguar pyramid comes from. There is a series of steps that we all need to follow in order to get to that excellence, right? And if you look a little bit deeper, you're going to see that each step is going to have be part of multiple different steps. Now, we know that around the world, we do about 15 million root canals a year. And those numbers come from the American Association of Endodontics. And what's cool about that is that we know that our work works very well. I love this paper by Salarabi and Rostein, where they look at 1.5 million patients throughout the years, and our survival rate is 96%. It's very difficult to think of any specialty on dentistry or medicine that have those high numbers. So it's really impressive. And we all have seen that, right? This is a case where this patient came back in 2010. He was a kiddo back then, did the root canal, followed those simple steps that we were talking about. And in 2019, the patient is going back to college, replacing the stainless steel crown, and the general dentist want us to make sure that the tooth is okay to be restored. And now we have the ability to see healing not only in 2 dimensions, but in 3 dimensions. That's the way we should measure ourselves for success. What's important, though, is to understand how to diagnose. And we cannot just condemn every single tooth that has a deep pocket like here or a deep defect and think it's a vertical root fracture. Again, you have to be a diagnostician first and then a good clinician. And when you follow, again, those simple steps, things are going to work. This is the best bone graft you can ever do. It's what I call endobone. And this is, again, something that we all see in our clinical practice. You see even more drastic cases that when you do things and follow those series of steps, things heals better. And I can tell you, if you look back to this case, this will be a nightmare for an oral surgeon to place a graft in here. I promise you that every single oral surgeon would rather, even if you lose this tooth for whatever reason, would rather place an implant on this final x-ray compared to how initially things look like. So, but you know what? When you practice long enough, you're going to see your own failures as well. And this case literally just happened to come back for a follow-up the day before I was going to Egypt. This was one of the first cases that I treated in private practice, Eastern European lady with very hard filling material to remove. I don't remember if it was Russian red or what, but very, very difficult. We did what we could. It's not my most sexy root canal, but things worked very well. She came for a 1-year follow-up. You can see how the lesions were pretty much healed. And then 15 years later, this is what happened. Now, did this happen because of our aggressiveness on trying to remove an opening in that canal? Did this happen because of the patient's occlusion? Is it a combination of things? You don't know, but the reality is that nothing in life is permanent, and dentistry is not an exception. A lot of things that we do sometimes are temporary. So this is the tooth cycle of death that I have talked about. And as endodontists, we need to be very conscious. And our main purpose should be trying to reverse this cycle. And I think from the AAE and all other associations are working on getting better at understanding the regenerative procedure. But until then, we need to do every single effort to keep those teeth in the mouth. And why is that? Well, we know that tooth loss is a significant biomarker of the health condition of the patient. We need to start thinking about that, and we need to start thinking that dentistry cannot remain disconnected from medicine when the biology is one and the same. Those are words from Dr. Miguel Stanley from Portugal, one of the most influential dentists in Europe, and I cannot agree with him anymore. We need to stop thinking on just mechanics, cosmetics, or local work, right? We need to think on the overall health of the patient and integrating dentistry into medicine. And interestingly enough, we have a few reminders at the very early of this year. These two that are more on the periodontal world. But over the last couple of weeks, we've been receiving this paper from the ADA, which literally hit our home right there, right? How endo, when you treat successfully apical peritonitis, is going to reduce your systemic chances of inflammation and mitigating cardiometabolic risk. This was a paper where they were looking to almost 40 different factors. And when you treat apical peritonitis appropriately, you're going to decrease almost 24 of those factors that we're measuring. So it's time for us to change our mindset. It's time for us to, again, start thinking that we're not just treating a tooth, we're not just treating a symptom, we're treating a patient, and the longevity of our cases are going to influence and have a huge impact on this patient's life. So what can we do to increase that overall life of the tooth and again, overall health of the patient? Well, we need to be aware of this term of pericervical dentin. What is the pericervical dentin? The pericervical dentin is the dentin that is 4 millimeters above and 4 millimeters below of the CEJ level. And why is that pericervical dentin relevant? Well, it's the dentin that is going to support all the occlusal forces, and it's the dentin that we cannot replace with our restorative work. So again, we need to be good and conservative with it. So when you think on our classic hand files, if you look at a regular K-file O2 taper, you can have a 0.1 millimeter at the very tip of what we call D0, and then it's going to start increasing by every millimeter, 0.2 millimeters. So at D4, we'll have an 18, and D8, 26, and so on. Well, when we look at our numbers on our rotary files, this is a file that I used for the longest time, Wave 1 Gold. At D0, it has a 0.25 millimeters. But what happens with the maximum fluid diameter? These files are a little bit more conservative, a little bit more aggressive than what we should be using. It's 1.1 millimeters versus the files that we're going to be introducing today. Even the glide path that they have with that system, the Pro Glider Gold, it's more aggressive than these actual files. So there's a quick representation here, and we can see the trend where most of the new or newer files are trying to get smaller maximum fluid diameters, and that's where our specialty tool kind of start thinking about. The file that we're going to be introducing today, it's a different file. What do I mean with that? Well, it's going to be as efficient as what we're used to, but it's going to preserve and have that biological concept of keeping the pericervical dentin and still allow us to manage all these complex anatomies that we know since Hess times. This is what we call nano sapers. And the interesting part about these files here is that they're made out of a different nickel titanium. They're made out of black nickel titanium. And what does, it's going to be more resistant, and it's going to allow for us to manufacture files with a much more or much smaller diameter as well. And some other key players in the industry are starting to utilize this black nickel titanium. What's relevant about that? I want you to look at this picture. Don't think that those are diamond codes that are gonna fail in your preparation. This is purely illustrative on showing how pretty the file looks like. But what the nano coating is doing, it's basically an ion-based treatment on the file that is gonna allow for the file to be more resistant to cyclic fatigue. It's gonna prevent corrosion with the liquids and the irrigants that we use. It's gonna allow for you to use the file sharper throughout your whole procedure, and it's just gonna cut a little bit faster. So overall, the file has a 3% constant taper, which is pretty small if you think about it. It's gonna have a triple helix cross section where two of the areas are gonna be cut in, and then we're gonna have a lot of space for those debris to come coronally. And again, it's gonna have a very small reduced master fluid diameter. So the questions that I got when I got these files, it's how are we gonna clean those canals? Number one. Number two, are those canals clean enough? Number three, how are we gonna seal those? And last one is, can we transfer the heat to the apical flare if we believe on, again, doing a heat type of a warm vertical compaction? So again, this is where our mindset, and I'm going to show you this slide probably one more time, needs to start changing. This is the way my root canals used to look back in, again, from 05 to 2011 or 12. This is the type of preparations that we're doing right now. Now, if you have a conversation with your referrals, I promise you, they're never going to be against this type of shapes. Where you tell your referral that you're going to be able to maintain more tooth structure, that is going to have the same type of success, the patients are going to be as comfortable. They will not care about the taper of your files. I already had those conversations with mine, and I only had good feedback, and that has never been an issue. So the way Avalon proposed to do this type of cases is like any other traditional system that you use. You open your canal, get your number 10 file to working length, and then just do a traditional step back. What I've been doing, just because I have fallen in love with this file, is using my C glider, and then I go with these files here. It's really important, if we're going to try to use this type of technology, to use some type of irrigation devices to activate your irrigants. And you'll understand why in just a minute. And the way I like to seal these cases is with bioceramics. So let's go step by step, trying to answer those questions that I had. So on my daily practice, any tooth that I will see, I will open the tooth up, I will run the first cycle with my laser. And the purpose of doing that, as soon as I open the tooth up, it's to, number one, reduce the load of bacteria. Number two, remove tissue. Number three, allow more and better visibility. As soon as I finish with my first cycle with sodium, I go with my glider to my estimated working length. And at that point, that's the only time that I'm going to use hand file, which is my number 10 hand file to get my working length. And after that, I'm going to go and do my step back until I feel the canals are clean enough. When it comes to your regular irrigation, which you're going to be using every time you put a file in there, you can still use your metal syringes as long as they're safe side. I like this IrriSafe better just because they allow you to get more control on around the curves in every canal. But again, that's a personal preference. And once you're done with your clean and shaping, I personally like to use the Photona laser. And I'm using the protocol that Dr. Giovanni Olivi taught me 4 years ago. And that's what I still use. I use the sweeps mode and again, do 2 cycles of EDTA for 30 seconds. You always like to let the irrigant rest for 30 seconds in between cycles. So that's the boring part about it. But through those 30 seconds, it's pretty incredible the activity that you see on those irrigants. And then you use water to try to prevent any type of interaction between the liquids, even though there's not a lot of evidence that EDTA and sodium create any problems. And then you do last 3 cycles with sodium hypochlorite. So I want you to see with this extracted tooth, because I can show you what I do on my clinical practice. You're not going to see a whole lot on the action of the laser. So this is the best way for us to show you what we do with the laser. And this is a video courtesy of my good friend Jose Aranguren using these files that I'm talking about, the nanosapers. So that's the first file going into the mesobuccal canal. By the way, this is an extracted tooth that is a complete replica of a real tooth. And what we have as a pulp tissue, it's wax, which is very difficult to remove. That's the distal canal. I'm going to the mesobuccal in just a minute. Using a little bit of irrigants to see how the canals start cleaning that. And it's going to be very interesting because what you're going to see is what we know from the literature, how no matter what files we use, the files alone don't get to clean more than 70% of the tissue on the root canal. So when you think on those studies that we were talking earlier by Salarabi and Rostein on the 96% survival, it's pretty incredible. So again, right now we're just using regular conventional needle irrigation, which is what I do on my cases. And you can start seeing some of that wax being gone. And we're gonna go with our last file here with the 2503. Distal canal, mesobuccal here, and mesolingual. And again, the anatomy of the canal, the original anatomy hasn't been altered whatsoever. I want you to pay attention that we go to length, take the file out. There's no need for us to stay a long time at the apical area. So regular irrigation, and this is truly what you will do on your regular cleaner shaping and irrigation, right? Well, let me show you in just a second. We're going one more file. We're going to go to 30 on this one. Okay. And again, you get an idea on what we've cleaned and disinfected with our files and just our regular UV-safe type of needle. So here's where we're gonna get our laser, okay? And so the way the laser works is by absorbing the water. If you activate the laser there without any irrigants, you can see that the laser is doing nothing at all, right? As soon as you start putting liquids, look at the amount of movement. So this is what I want you to see. And why do I choose Photona? Again, I was kind of suggesting my Avalon friends to have maybe a seminar with 2 experts on lasers, different type of companies, as well as with Endo, because you definitely cannot do this with any other type of technology. I don't care how good ultrasonics are. The photoacoustic streaming that you get with with these lasers is just unbelievable. And I want you to pay attention to what's happening on this area here, as well as all the pieces that we haven't even touched at all. Okay, so that's the first round of laser. This is our second round. And again, the reason why we use wax is to try to simulate biofilms inside of the canal. And as we go in the second cycle, you can see what's happening. Now, questions that I always get, obviously, is there any extrusion through the foramen? Yes, if you over instrument, if you don't take care of your working length, you may have that. But as long as you do what you're supposed to do, you're going to obtain this type of results. And this is our last and third cycle. So again, to me, this is really impressive. And that's the results, the type of results that we want to ultimately get when we're doing our root canals. And that's another example, just looking at the mesial root of a lower molar as well. Again, you can see how we cannot touch those isthmuses with our regular root canals, and look at what the irrigants do with the laser. Again, the one thing that I love about Photon is that you don't have to put it inside of the canal. You don't have to risk charging or transporting or again, touching that canal whatsoever. So, and then when it comes to operation, I think the cleaning part, it's pretty clear. I get lots of questions on whether we need to use bioceramics or not. And I think that question is already been answered. Seems like bioceramics is a superior material. When it comes to the handling, it's a little bit easier to handle than warm vertical compaction. The question should be, what type of bioceramic are we using? Because I'll tell you what, not all the bioceramics are the same. And so, as we know, the endosequent BC sealer has been around for almost 20 years, and it's a fantastic sealer. It's the sealer that I have used for the longest time, and I have a lot of respect to it. And that probably will be the only sealer that can compete with the Neo sealer Easy Flow. When it comes to the percentage of bioactive material, endosequent only has 5% less than the percentage of Neo sealer Easy Flow. The rest, I don't know if we could even call them bioceramics, to be honest with you. And then Gustavo Dideos gave us a fantastic lecture a couple of weeks ago, and I love seeing his results. Gustavo is one of the guys that I have followed since even before I was an endo resident, because his research is top. That guy doesn't bullshit. Sorry for the question, for the word, but what he'll tell you straight. And what he told us a couple of weeks ago is that he was comparing several bioceramics. The way he's doing it is he's using H plus as the control and BC sealer as the control of the bioceramics. And when it comes to healing outcomes, all three sealers have a very similar outcome on the 98% healing, and only 2% were on healing each category. The speed of healing was significantly faster on Neo sealer flow. And then the resorption rates, which I know a few of us are being concerned with the resorption of the BC sealer, the Neo sealer seems to behave better. So he's Gustavo talking about, again, if you have two bioceramics with the same healing, it only makes sense for us to use the one that heals faster and has better resorption behavior. When it comes to the technique, this is a very easy representation where we apply the sealer, only putting the syringe on the mid-third of the canal, extrude it, then we put the carapace, and again, whether you want to go and transfer the heat to the middle third or just cut it at the orifice level, it's up to your preference. The boys at Avalon were asking me to do a little video about the technique, since it hasn't been shown that much. The one thing that I like to say, I don't like the term single cone operation at all. It gives us the kind of excuse to just fill the canal with a bunch of sealer, throw a cone in there, and that's that. And I don't think the technique was made for that. The technique was created to definitely simplify the tedious form vertical compaction technique. Um, but it requires some technique where you want to try to match your preparation to your cone and understand the way this sealer works. So the first part is the sealer placement. And what I wanted to look at is if you try to use these tips, there may be a little bit too thick if you're doing conservative or minimally invasive endodontics, right? You don't want that tip to be binding into the canal. So as I told you earlier, I like to place the tip of the sealer right at the middle third. I don't like to go to the apical level because it flows really, really nicely. And especially the smaller the preparation, the more it seems to flow. And you always want to see the sealer flowing coronally. You don't want the sealer to extrude apically. Once you place your gutta percha, three things that are key, and I know that everybody in the audience knows that, but you want to make sure that the gutta percha goes to working length. If it's not going to working length, it's probably because you have back some debris. Let's go back, re-irrigate, recapitulate, and you'll be able to take it down to working length. The second part that is very important, especially doing minimally invasive endo, is having a top back. Why is that? Because if you don't, you're going to put your heat system, it's going to be very frustrating for you to upgrade because you're going to pull the whole cone with the heat unit. So make sure that the cone is fitting apically and not just currently. And the last part, I always and still like to have my cone fit X-ray confirmation because that's the last chance you have to make any type of modification. So at that moment, you go with your heat unit. And the beautiful part about this gutta percha is that it's been modified in the lab to where the heat is going to be transferred to the next 3 to 5 millimeters from my experience. So again, you're not thinking of putting the heat system all the way to the last 3 millimeters. You just go to that middle third, compacted, and then you're going to get with your backfill unit. And then again, some people like to do the whole backfill in one shot. I usually like to do it in stages of 3 millimeters. Again, the rest, once you're done with your compaction, the way I like to clean all the sealer excesses by using my sandblaster. That's very important for me as a restorative dentist and some of my referral dentists that prefer to do their restorative work. I want to make sure that I want you to see the way this works. You sandblast the preparation, you sandblast the walls, and the walls look as clean as pristine as they can. Okay. So what are the indications? Well, I'm going to show you basically a case per recommendation that I have here. But what I always talk in my lectures, if a file is good enough to deal with every challenge that we present, the answer should be that you should be using it always. Not that I get to see that many simple cases, but again, I cannot think of any case that you will not use this file. So first patient is a 65-year-old Caucasian female. She is referred to my practice with pain on the upper left side. When it comes to the dental history, number 13 has had a history of a root canal back in 2008. It wasn't done by me. The crown was replaced 6 months ago. And then number 12 had a crown replaced 2 years ago. Since the crown was replaced in number 12, the patient has had intermittent pain that has come and goes. The general dentist thought it was probably sinus-related pain and visited the ENT. The ENT has prescribed antibiotics and steroids on 2 separate occasions. But again, the pain has consistently been there. So finally, they referred the patient back to me. I wanted to see the limited opening on this patient. And so that's as big as he was able to open. When it comes to vitality, Uh, Tooth number 12 was -2, cold and very tender to percussion and palpation. We were kind of watching this tooth here since it was completely asymptomatic and done 7 years ago. We discussed about the potential of opening, but again, the patient opted to monitor, which I think it's the best treatment protocol. When you look at the 3D examination of this patient, I want you to take a look at it, and then I'll highlight you in the next slide what I'm seeing. So I think everybody by now has seen that lesion right here on the buccal aspect of that root. But when we're really convinced, you have to look at the overall picture. And every time you get to see a radiolucency on the side, you're going to expect a lateral canal on it. And so that's our final result. Luckily, we were able to get into that lateral canal. And again, you can see on this picture the title of the presentation, past, present, and very likely future of endodontics in one picture. So the way we instrument that case on this buccal canal, we use the 2503, the palatal. That was my very first case with these files. I took it to 30 just to have fun and to see how easy was the transition between the 25 and 30. So my second case, by the way, you're going to see that those two first cases were relatively easy cases. That's the way I typically recommend every clinician to do the transition. Don't go through the craziest tooth with a brand new system that you don't know, that you don't understand, and that you're not familiar with. I always like to start playing with a new system on straightforward cases. So that was a second case, 55-year-old Caucasian male, patient referred with pain on the lower left, on the lower right quadrant, sorry. 30 and 31 had history of root canals and crowns in 2019, and then 29 has been treatment planned to be replaced for more than a year. You can see the recurrent decay. This one seems to be happening the same thing. So 29, as we were expecting, -2, all, again, very tender to percussion and palpation. We have proposed to do root canal, plus minus apical. And so when you look at this combine, again, I want you to see what you see, and I'll tell you what my concerns were with this case. So my two concerns with this case, one, the proximity with the mental foramen. Even though it's far enough, you always want to be careful, both with your instrumentation and two, with your sealer placing. And two, again, when you see the lesion not in center on the canal, you need to be suspicious on a potential lateral canal or second canal. So that's exactly what happened on the post-op. I never got to, or I was never aware that I instrument that second canal, but I was relying on my irrigation techniques. I was very aware that the apical zone was probably very complex, and again, very nice conservative shapes. Even when you compare to this case, which is a pretty conservative instrumentation, you can see the difference again on the shapes of those teeth. So this case was taken to a 2503. Instrumentation time probably was less than 5 minutes. Incredibly efficient system. Case number 3. Again, the first case was relevant for, again, limited opening. You still have the ability to prevent those files like you do with the or any files of Avalon, truly. That second file, again, that second case was just showing you a relatively simple case. Number 3, it's something that you probably will see on your practice. The classic case that referral tells you, please be conservative with your access cavity. I just prepped this tooth. I don't want you to modify my preparation. As soon as you complete the case, I have the crown to cement it. So you can see the obvious lesions on both mesial and distal, and the results were, as we were expecting, negative to vitality, percussion, and palpation tenderness. And so, again, we're going to look at the scans again, and I'll show you in a minute what I highlight about this scan. And as you go through that, it's very, very important when we're looking to that, not only to look at the number of canals, but we need to pay attention to the root anatomy, right? And when you look at the root anatomy, you're going to see in a minute what I'm talking about. So this tooth drained for quite some time. I placed calcium hydroxide. When you look at that calcium hydroxide, you may think on the axis being a little bit too rough. Again, pre-calcified canal, but when you look at the post-op, the reason why it looks a bit wider is because of the extra anatomy that we have. So two things that I want you to look at. I'm going to go back real quick. When you look at the cross section of this mesial root, look how wide it is from a buccolingual dimension, but I want you to pay attention how skinny this root is from a mesial to distal direction. And anything larger than an O4 taper will probably create a strip perforation, especially on that middle mesial canal. And eventually you'll get a lateral lesion that will fool you as if it was a crack. So I was very happy with the way this case turned. You can see, again, how small the tapers are, and again, how much dentin we have the ability to keep with those. Calcified canals, I think that's the classic and only anterior type of case that I get to see nowadays on my practice. This is the classic trauma case. Patient has been asymptomatic forever, and then for whatever reason, the patient decides to go through ortho, and then possibly through ortho disrupts the environment, and now the patient develops a lesion and pain. So when it comes to deal with these patients, obviously, when you look at the contralateral tooth, it's a very calcified canal. Bulb chamber obliteration is not an indication for a root canal, but once the patient starts having symptoms and developing lesions like that, obviously, you need to fix that, right? There's a lot of conversation right now about how to deal with these type of cases, whether we use dynamic navigation, whether we use static navigation, or doing it with free hand. My friend Mo Fayed is doing a workshop now in the AAE. It's getting a lot of attraction, and it's getting close to sold out on dynamic navigation. I've been doing so many of those that I have become pretty efficient on just, again, guide myself by studying the 3D. The way I do this type of cases, I always start with a long surgical round burr number 2. If I need help, I go with the mouse burrs as well as with the ultrasonics. And so, again, this is the way and the final results. We have the ability to keep not only our access cavity really small, but there's no need for us on a tooth that is calcified all the way to the apex to remove any unnecessary tooth structure from the coronal or mid-third. So I think this is a very good treatment for the patient, and we'll be able to maintain that tooth for the long term. Case number 4, very sick patient. I forgot to put that on the medical history. 80 years old patient he was playing baseball a long time ago with his grandkid. The baseball hit his mouth, a balls, 2 teeth, and ended up getting braids on the upper and a few crowns or a lot of restorative work on the lower. So this is the clinical pictures. The patient's going through a bunch of radiation. The referral is asking us to try to keep x-rays to the minimum, and they beg us to not take our PAs. I took my scan, and you look at the scan in a minute. Nothing really relevant on the upper tooth, just a classic lesion from that trauma. Pretty large canal. I told you a minute ago that I don't get to see easy cases. Well, this was one that was relatively easy. And then the lower tooth, we look at the resorption defect and the lesion on the other lateral. So even though there's a little communication with the lingual aspect, when the resorption is that extent and it goes so epically, I try to do the best that I can to clean this type of cases internally. I think going with surgical repair on this tooth will create more problems than solving anything. So this was a perfect case to see and to use this type of files. One, because look how small the taper is here. It gets larger as we go epically. So we were able to use all the way to the 50 file, still managing to be very conservative at the coronal aspect. And again, this is a very long bridge. So the more tooth structure we keep, the better for the result. And then for this big resorption, when I show you the final result, you're going to see here 2506. And that's where, as endodontists, we have to make the choice, right? I opened the tooth a little bit more at the coronal aspect because I wanted to be able to pack my bioceramics on this resorption area. And with the O3 taper, I wasn't able to. So I ended up opening it up to a 2506, fill with the cone all the way down here, apply the heat system, and then pack with a BC patty this area, and then got a perch up back. Next case, it's a 3-rooted premolar. Every clinician can see that. The difference or the challenge of this one here was not only deal with the 3 roots, but deal with the apical resorption. Those apices are not easy to manage when it comes to obturation. And so again, I want you to pay attention on how small these roots are. You don't want to over prepare those, or it'll be a recipe for disaster. And so here you have the kind of synopsis of where we are, relatively decent split when it comes to depth, lesions on all 3, and again, very, very small conservative roots. You have a lot more room for error here, not a whole lot in here. And so again, this is another example showing small, slim preparations, large apical diameters, still managed to do minimally invasive dentistry. We went to a 50 on the distal buccal, which was the one with the biggest resorption, 40 on the palatal, and then 30 on the mesial. Cracks, that's a big hot topic here. Lots of lectures a day last year. And I'm kind of blessed that I work on a building where we have a few phenomenal restorative dentists. And this was sent by one of them. They couldn't figure out whether it was the molar or the implants were causing trouble or both. And the reason why is because when they did the cold testing, they had some response to the thermal response on number 3, which based on the x-ray, you will not expect that, right? So we did our testing, take some pictures, and I asked them whether they want me to do the exploratory root canal or if they prefer to prep and determine the restorability. So they went ahead and did the first step because I was concerned with the cracks. And once they prepared, they told me, Antonio, you know what? I think we can save the tooth from a structural perspective. So let's have a look at the scan. And the one thing that always concerns me with these type of cases is the coronal aspect of the tooth. If there's a deep pocket associated to the fracture, I'm not a big proponent of saving those teeth. But again, you can see that the lesion is pretty much isolated at the apical level. You can see how the sinus it's affected by that. And again, it's another case where you're thinking, why this is so large here? Well, we have another case of a three canal molar, and it's awesome that all this have happened within the last 3 weeks that I've been playing with this file. But again, when you study the case, you know that this mesial root is going to be a complex root with three canals there, fused mesial, distal and palatal root. So those are truly the cases where the laser are going to be very, very effective. Back on the day, we'll get all three canals here, we'll get the distal and the palatal, and we were not able to clean this in a predictable manner. And I think the laser technology is going to make a difference on these type of cases. So we clean the mesials to 25, other than the MB to 30, and then the distal buccal to 30 as well, palatal 40. Resorption cases. Resorption cases are especially internal resorption cases that we want to definitely maximize even more so on your coronal aspect. When you look at the scan on this one, and I didn't want to do the full scan, you can see that this is the classic internal resorption. There's no communication whatsoever. There is already resorption at the pericervical dentin that dentin has been lost due to that. So, excuse me, you want to be as conservatively as possible using, again, a system that removes as little dentin as possible. And I'm about to show you even a more damaged tooth. Now, this case here not only has internal resorption of the coronal third, which again, it's not very typical that I see those. I get to see much more cervical invasive resorption cases. But again, it happened that over the last few weeks, I saw this too. And so again, when it comes to diagnosis, basically what we were expecting and anticipating. Let's have a look at the 3D. You can see the cavity there. And you're going to see that distal root here where we have that big resorption here, big resorption there. Again, if you over-instrument, you're going to create a perforation in that danger zone that you want to avoid. So calcium hydroxide, the first one, and then the final X-ray here. Again, I wanted to see the angle view just to make sure that we seal and took care of all that resorption. And again, this is not made by my files. This is purely the laser activating and removing all the tissue from there. And you can see how those files have the ability to maintain those curvatures. So again, pretty conservative sizes and tapers, and to me, a beautiful result. And that was going to be my last case. I'm going to show you one extra one in a minute. This is a tooth that has been treated by a well-respected endodontist in the area. He's opened the tooth twice, and the patient's still in pain. So before taking the tooth out, they want a second opinion. Tooth is tender to percussion and palpation. And you can see how we have a lesion on the mesiobuccal root, and very likely probably second canal here, right? That's what we discussed with the patient. We discussed between retreatment and apical. Patient want to do save the tooth. As you can tell, they have implants on the area. They're familiar with the implant, and they want to do everything possible to maintain the tooth in the mouth. So this is an incredible case to show you, again, two different type of instrumentations. You have the ability to do the same type of cleaning using this type of technology that it's much more conservative, in my opinion, better outcome for the patient and the overall health of that patient. And this is a case that I was supposed to finish on Monday. Another case finished by a different endodontist As soon as you open the case, you can see this white dot in there, and then the two main canals in the mesial. Um, that's the difference between our instrumentation and the previous provider, right? So that's going to give you a good idea of how conservative this 0.73 millimeters diameter versus a 1.1, probably 1.2 diameter. And that was the last case that I finished on Thursday night or evening. That was a little bit of a challenging diagnosis because the general dentist was convinced that this tooth was the tooth causing trouble, and they were suggesting to extract that tooth. I'm about to finish. This is the very last tooth. Um, the key here is extreme temperature sensitivity. So you're not expecting any temperature sensation at all. You do your testing, you're going to find out how there's lots of decay on that tooth. And if you've been in private practice for a while, when you start seeing those type of shapes where the root profile doesn't follow the actual tooth, you need to think on either the root being kind of rotated or there's going to be a bad curvature in there. And when you look at the scan, you're going to find out that unfortunately was the last part. Very wicked tooth. And so I was very excited about this case because it was finally a good, big, challenging case for using these new files. So you can see the mesial, you can see that distal right there. And again, the distal buccal right there, mesial buccal right here, goes around there, and then the palatal root that curves a little bit as well. So I'll tell you, this was a challenging case that even with these nano shaper files, it took me a while. It took me a while because the split was pretty apically, and those roots were very, very curvy, very demanding. So on this particular case, I had to recapitulate a couple of times with my hand files. And again, I want to thank always, every time I lecture, this group of people that made me be who I am, my parents, my mentor, Rafael Miñana, Mari Carmen Navarro, and my two partners, Pete Witherspoon and John D. Regan. Obviously, thank you to my family, my beautiful wife and kids for being my support and the reason why I do what I do. Questions? Sorry that I ran a little bit over time, just 2 minutes, but thank you everybody in the audience and hopefully you enjoy. Let's go to the questions and then DJ or Jason, you talk about this slide later on.
Sounds wonderful. Thanks, Dr. Berto, for doing this. A couple quick questions here that rolled in. What is the first file you introduce into the canal? And do you leverage any type of orifice opener?
Fantastic question. So, look, that question needs to be answered with some thought process. Depending on your level of experience, you're going to feel more or less secure. During my first probably 5-6 years of private practice, the first file that I will always introduce was a 10 file. That 10 file will talk to me and tell me the areas that were more challenging. I have changed that over the last 10 years to where, and especially over the last 5 years that I've been using the Photona laser. As I mentioned earlier, I access the tooth. I do what I call conditioning of the tooth with the laser. That helps me removing a lot of the tissue, give me more visibility. And as soon as I see the canals, I get my glider, my C glider file to my estimated working length. That C glider gives me the same feedback as I'm using it on the motor as the regular hand files used to give me. Like you learn as a clinician to get feedback from your rotary files as well, and you know where and when you can push a little bit deeper and when you shouldn't. So again, typically my first file for the last year is now the C glider file, and after that I go with my and again, this is a file that I've only been using for the last month. So I'm giving you some of the cases that I've done over the last month, and so far it's been working very, very well. So after the C glider, to answer your question, I go to the nano treat files, the nano shapers. I'm finished on again the way the files talk to me. I want to see that apical aspect of the file, and the fluid's been kind of clean and nice. And again, I study the 3D X-ray and the combined CT very carefully and decide what size we use for that. Now, to answer the question of the orifice opener, um, can you use it? Absolutely, you can use it, but it's counterproductive, the use of an orifice opener when we're trying to, again, maintain and keep as much coronal tooth structure as possible, because what that orifice opener is going to do, it's opening your canal bigger than what these files allow you to maintain, right? And so the pros about using an orifice opener, obviously it's going to allow, if you're not using any type of activation on your irrigants, it's going to allow for you to get your irrigants deeper to the apical aspect. It's going to prevent from you to get in trouble. It's going to remove that resistance coronally. But again, that's kind of the opposite of what we are trying to, the message that we're trying to deliver here. We have files now that allow us to, again, instrument with smaller access cavities coronally, as well as on the orifice area. They're more flexible, they're more durable, they're more efficient, and therefore we don't need those orifice openers anymore.
Fair enough. Is there matching gutta percha to match each
Yeah.
file?
And that's a huge one, because I'll tell you what, I called BJ the first day that I used them, and I told him, BJ, I love these files, man. They're amazing, but I cannot fill those cases. I have to go to my slim shapers and then finish with the slim shape, because the slim shape gutta percha doesn't go to my work length. And I don't like to rely exclusively on the sealer, because I was taking x-rays and the sealer would go perfectly, but I knew the gutta percha wasn't going to my length. And he told me, Berto, you're done, man. That's exactly what he told me. Right, Vijay? No, he told me, man, there's a gutta percha, cones that actually match the preparation. And
Perfect.
amazing. My dental assistant had taken them away from my files, and since day two, I started using them. And yeah, it fits like a glove. I love them.
Perfect. Kind of along that same lines, Dr. Berto,
Yeah.
how do you confirm the tug back is true and not false, since the taper is only 3% and coronal binding is common in such preparations?
That is true. Again, that's a very hard one to do. But as you're putting your cone, you're trying to see that gutta percha. If you have that coronal tuckback, you're gonna see that gutta percha binding at the orifice level. Again, much harder. That's a very, very fair question. Much harder to determine the tuckback from these type of preparations, but truly, it's more of a tactile sensation, radiographic, and when you're applying your heat over there, if it's purely coronal, as soon as you apply the heat, the cone is gonna come out with the heat unit, probably.
Fair enough. Since you mentioned slim shapers just a minute ago, are there any advantages of nano shapers over slim shapers?
Well, the only advantage is that you're gonna keep your coronal structure a little bit more conservative. That's one. Number two, and again, that may be purely a clinician situation, but I love the Slim Shaper number one. I feel it's one of the files that allows you to push more than any other file on the market. but I usually have a little bit more challenge, if we want to call it, going from the one to the two. Not that I cannot go, but it takes me a little bit more time. And again, when the file is talking to me as I go in the canal, tells me, "Hey, chill, don't push me the way you push the Slim Saper one." Right? I didn't see that on the transition between the 15, the 20, 25, even all the way to the 50 with the nano shapers. I saw that the transition was nice and smooth in every single file. And that may be related to the black wire. I don't know.
Yeah, there's another question kind of along similar lines of what are the differences structurally and clinically between
Yeah.
the slims in regards to the austenitic setup
Sure.
as well as the body
So
temperature?
the RPMs torque exactly the same way. The way you're using the file, again, step back technique where you go to length with every file. Um, the metal feels different for sure. Both equally efficient when it comes to speed. Again, um, they're both such efficient file systems that it's hard to tell. But I feel like the nano shapers work a little bit faster in my hands, mainly because of what I was telling you. I don't have that fear factor that I have on going on the transition between the Slim Shaper one and two.
Fair enough. I think that addresses that. Bendability, obviously being able to access a patient's mouth going open that big. How do the nano shapers hold a
Again,
pre-bend?
the metal feels different than completely different than any other file that you have used, and that's the black nickel titanium. You can see this picture here. You can bend it as much as you want, and you can prevent it as much as you want. That was one of my biggest concerns with the first case that I presented. The patient literally opened 10 millimeters. Again, no issues with that. You can prevent them, and the beauty that you have in every file from Avalon, you have it as well with the nanoshapers.
Fair enough. One more question about the files, and then we're going to go to sealer. Number of uses. How many uses are you using on the nanos?
Well, I'm a big advocate for single use only. That's been the way I practice ever since I became a dentist in 2005. And I don't think I'll change it. You may ask me whether I see unwinding on the files. I don't see unwinding even on the most complex cases. Uh, I want to give every patient the opportunity to use brand new files. Um, I don't want to lose any efficiency. I don't want to. I don't know. Like that's more of a philosophical um, answer, maybe. But I've been single use files since the beginnings, and I'm not willing to compromise that. Can you
Fair enough.
use it on multiple times, multiple cases? I'll tell you that this file doesn't feel any worse than the Slim Sapers. And when I was introduced to Slim Sapers several years ago, BJ can tell you I did probably 100 blocks in a row with one single file, and they were like nice curvy blocks. So in terms of usability, I'm sure you can use it several times. Uh, is what I would recommend. No, I'm a big proponent of single use only.
Fair enough. Question around sealer. What did you mean by sandblast to the sealer? What is the use of that?
So um, there's times when you try to um, remove your sealer just with your water syringe and spray air, and the sealer stays either within the crown or on the walls. Uh, I hate taking a post-op X-ray where you think everything looks good and there is a little bit of sealer on the side. It doesn't look clean enough. The sandblast um, kind of again removes all the remnants of sealer and it creates this nice pristine look on the walls that it almost gives you the impression. And again, I'm not sure if that will have any impact on the restorative dentistry. I know that most of my prosthodontists like to sandblast their preparations because there's better bonding when they do that. So those are the two reasons: cleaning all the excess of sealer that is on the walls, and again, hopefully increasing the bonding to those walls.
Great. Do you see the need for a thinner or less viscous sealer in comparison?
No,
No.
no,
Okay.
no. The AC flow flows perfectly fine.
Wonderful.
Yep.
What is the difference between the Z glider and the Nano 15?
Um, the the metal for one, and then the cross section, I believe, is not the same. The nano saper, it's again regular nickel titanium. When it comes to the cross sections, to be honest with you, I believe the uh, you'll need to answer that for me, guys. As far as the tape
Mhm.
of the Sea Glider, I'm not sure if it's an O2 taper or if it has any modification on the taper through the file. I don't remember that. The nano sapers are constant three taper, ion treated, and black wire. So in terms of the cutting efficiency and the feel of it, um, it's definitely a different feeling. Like you feel like, and again, it may be because I already have used the sea glider in the canal, but it feels like the nanosaper goes even more efficiently into the canal than the sea glider.
And,
Fair
and
enough.
Dr. Berto, with that in mind, there are a couple of questions behind the scenes on CBCT use. So
Mhm.
there was a question talking about lower incisors with resorption.
Yeah,
What's your prognosis to you discuss with patients based off of what you've
absolutely.
working with it
Yeah,
in the past?
yeah. So um, again, I am kind of privileged to work on a fee for service, very high end practice, and work with some of the best, if not the best, restorative dentists on the area. And again, the way we start our lecture on, again, keeping teeth, it's our main objective. We know that there's going to be cases where the prognosis are more questionable than others. And that's a discussion that we have with every single patient, especially on that resorption case. Um, we have the discussion with them about potentially need to do some type of surgical intervention if we feel the perforation is too large or any bone gets affected. We even discussed potentially again, and that particular case was not a great option, but the potential of replantation and fix the defect extra early as well, bringing the oral surgeon or the periodontist that we have on our building. So yeah, those are careful conversations that you have with your patients, discuss the pros and cons of each procedure. Um, but again, ultimately, our patients and a great majority of them had experiences with implants, and I feel like the pendulum is shifting. A lot of these patients have seen what it takes to get an implant done, not only from a financial perspective, but also timing and complications. When an implant fails, I'm telling you, that's not a fun uh, problem to solve versus worst case scenario. If this case fails, you still have the ability to, um, again, do an implant or bridge or whatever you think restoratively. So, but
Right.
yeah, those are very careful conversations we have with patients. And our first visit, even though we oftentimes offer treatment on that first visit, we probably spend more time with our patients, educating them and trying to get some basic understanding of what's going on and why we decide to move forward in one direction or the other than many of the other practices. Yeah.
Perfect. We have one last question, and this comes from way up north. And you might know him from a good friend. I won't mention him, but he says he loves your presentation and he loves the Slims and the Neo. And he's excited to try Nano. But What dynamic navigation do you use?
I do not use dynamic navigation. That's something that I have played with Dr. Mo Fayed. Um, and we have been working on doing that workshop at the AAE. I don't currently use any dynamic navigation system. This is my dynamic navigation, these three fingers here. I do a lot of pre-planning with my combine. I study the case on the combine CT, and then you correlate what you're seeing in the combine with the inclination of the tooth. But yeah, I don't use any guides or any dynamic navigation currently.